It is my distinct privilege to introduce, I already introduced her, but Dr. Hedy Kindler, who is one of the global experts and a rock star in mesothelioma. She's been an incredible resource for me. She and her team have been there for all of us as we've put this conference together. They've brought in their people to lead sessions. It's, Dr. Kindler has been amazing. I am going to let her introduce her session, Systemic Therapies for Pleural and Peritoneal Mesothelioma. This is a deep dive, really fast. So without any further ado, please join me in welcoming Dr. Hedy Kindler.
Good morning, everybody, and welcome to my adopted hometown of Chicago. It's really a pleasure to speak at this conference and to teach you a bit about systemic therapies for pleural and peritoneal meso. Now, Shannon's already given you a wonderful overview of the basics. I didn't realize she was going to do it that thoroughly, so I'm going to review it a little bit more as well. All right. And if I want to move this forward, I am aiming it. Oops. Oh, so this one is not moving with that one.
Oh, here.
So can I have, yeah.
I'll just adjust this. Oh. Now it will be.
Beautiful. All right, so I'll go from here. Again, I'm going to speak with you about systemic therapies for pleural and peritoneal meso. So, what the heck is systemic therapy? Well, the principal approaches to treating a cancer are observation, you watch it; surgery, you cut it out; radiation, you zap it with a beam aimed at the site of the disease. Pretty self-explanatory. Well, systemic therapy, you treat it with a drug to attack the cancer cells wherever they may be. Systemic means throughout the body. This can either be intravenous, by vein, which is most drugs for mesothelioma, or oral, a pill, a few drugs in clinical trials, and the occasional drug you can get outside. A few more definitions: first line or front line. The first type of systemic treatment you receive. Maintenance, what you take to keep the cancer under control after the initial therapy. Second line, the next type of treatment you receive when the cancer worsens. Neoadjuvant, treatment to shrink the cancer before surgery, and adjuvant, treatment given after the surgery to prevent the cancer from coming back. So how does the doctor help you decide which systemic treatment is best for you? Well, they look at the clinical trial data, which drugs are most likely to work in your situation. They look at some key characteristics about your cancer that might make one treatment more likely to help you. They look at your overall health, other medical conditions that could be made worse with certain drugs, or that could affect how some drugs are processed in your body. Now, before I talk about the trials, you might be wondering that I'm not going to be mentioning much about peritoneal. And that's because most of what we believe about systemic therapy in peritoneal meso is extrapolated from trials performed only in pleural patients. Unfortunately, most meso trials exclude peritoneal patients. There were no peritoneal patients in the randomized trials that led to the FDA approvals of Pemetrexit and of immunotherapy. It's actually challenging to convince pharma to support trials in this less profitable, uncommon disease. And trials that permit peritoneal meso patients often don't enroll many. It's an uncommon cancer, and peritoneal disease is often very vaguely shaped on a CAT scan. You need to know the size of something to see how much it shrinks with drugs being tested. If you can't measure it, you can't go on a trial. So there are only a few small trials exclusively for peritoneal meso, and none are randomized. We don't really know if all of the drugs studied in pleural meso have the same activity and side effects in peritoneal meso. So those of you with peritoneal meso, don't feel excluded when I don't mention your trials today. So what are the types of systemic therapy for meso? Chemotherapy, immunotherapy, targeted therapy, and I put in parentheses clinical trials, which will be the focus of other talks. So what is chemotherapy? Chemotherapy is cytotoxic. Chemotherapy kills cancer cells indiscriminately, usually by interfering with their DNA, the building blocks of life. Chemotherapy exploits the fact that cancer cells usually grow faster than normal cells. Here are some of the commonly used chemotherapy drugs for mesothelioma. Now, as doctors, we have to use the trade name, but as patients, you usually know the brand name. So there's Pemetrexit, or Alimta, there's cisplatin, carboplatin, gemcitabine, or Gemzar, and vinorelbine, or Navalbine. The brand names are always easier to say. What is immunotherapy? Well, logically, immunotherapy drugs target the immune system. The immune checkpoint PD-1, or programmed death receptor 1, allows cancer cells to be hidden from the immune system. Immune checkpoint blockade drugs turn off the brakes in the immune system, so now the body can attack the tumor. They unmask the tumor, and your body can attack it. Some immunotherapy drugs used for mesothelioma are shown here, including pembrolizumab, or Keytruda, nivolumab, or Opdivo, and Ipilimumab, or Yervoy. Do immunotherapy drugs have fewer side effects than chemotherapy? It's a common fallacy. Not really. They just have different side effects. They can activate immune responses almost anywhere in the body. Now, the most common side effects are going to be fatigue, mild itching, rash, and decreased thyroid activity, but they can cause inflammation wherever they darn well want to, whether it's causing joint aches, or diarrhea and colitis, or inflammation of the lungs called pneumonitis. It's just a little less predictable than chemotherapy. What is a Pdl1 test, and does it matter in mesothelioma? So this is a test on a tumor sample that measures the amount of the Pdl1 protein on cancer cells. Pdl1 testing can be used to find out if your cancer might benefit from immunotherapy. If your cancer cells have a high amount of Pdl1, you may benefit from immunotherapy. If your cancer cells have a low or no Pdl1, you may still benefit from immunotherapy. In some cancers, it's a bit more clear-cut than it is in meso, and I'll show you some of the data. Now, what is histology, and why does it matter? Histology is what the cancer cells look like under the microscope, and you can see the epithelial in purple and the sarcomatoid in pink. There are three main histologic subtypes: epithelial, mixed, and sarcomatoid, or as I like to tell my patients, vanilla, swirl, and chocolate. Why does histology matter? Because chemotherapy and immunotherapy may work better in some histologic subtypes than others. So you always want to know the histologic subtype of your meso when choosing your treatment. What is targeted therapy? Targeted therapy targets the biology of the cancer. In some cancers, certain signaling pathways or molecular on-off switches that promote cell growth are abnormally switched on. Targeted therapy aims to turn off cell growth by blocking these signaling pathways. And in this little schema, I've shown you several of the common ones in meso, such as BAP1, NF2, CDKN2A, mesothelin, VEGF, etc. Here are some targeted therapies available for mesothelioma. There are the vascular endothelial growth factor inhibitors, or VEGF inhibitors, including bevacizumab, known as Avastin, which is given with Pemetrexit and platinum, or ramucirumab, otherwise known as Cyramza, given with gemcitabine. Then, in some young patients with peritoneal meso, who have something called an ALK translocation, where part of one gene sits on top of another, there are drugs that are approved specifically for that translocation, regardless of what type of cancer you have. And these are oral agents, including crizotinib, alectinib, brigitinib, and lorlatinib, ALK, anaplastic lymphoma kinase inhibitors. And then there are many other drugs that target the pathways such as BAP1, NF2, mesothelin, and others, and these are currently in clinical trials. Several of them are quite exciting, and hopefully soon some will be available commercially. So this is a table showing some key milestones in the development of systemic therapy for mesothelioma. And pay attention to those years. In 2003, we had cisplatin and Pemetrexit. It took until 2016 before we then had a positive trial of Pemetrexit, cisplatin, and bevacizumab. 4 years later, we had 2 positive trials in 2020 with RAMES and Checkmate 743, and then in 2021, 3 more positive trials. The pace of research is really moving fast. Things are changing. So these 5 positive randomized trials since 2020 have transformed our treatment paradigm and will affect the design of all future mesothelioma studies. Let's talk about first-line chemotherapy options. These include Pemetrexit cisplatin, Pemetrexit carboplatin, Pemetrexit cisplatin and bevacizumab, and Pemetrexit carboplatin and bevacizumab. So this study, the EMPhASIS study, compared Pemetrexit cisplatin to placebo in cisplatin, and it was the study that led to the FDA approval of Pemetrexit for meso. For almost 2 decades, Pemetrexit was the only FDA-approved drug for meso. The study was led by my former mentor, and I believe he was a co-founder of the foundation, Dr. Nick Vogelsang. And so for many years, this was all that we had. And if you're looking at, this is called a Kaplan-Meier curve. And so you have 2 arms of the curve, and if something is above something else, then that shows that people did better. And so here we can see a difference between the arms in the curve, and so that patients who did get the Pemetrexit or Alimta with the cisplatin did better than those who just got cisplatin alone. Now, cisplatin is the FDA regulatory standard, and it is a tough drug. Makes you feel like you got run over by a Mack truck. Carboplatin is much better tolerated, with less fatigue, nausea, vomiting, kidney damage, and hearing loss. So the combination of carboplatin and Pemetrexit is commonly used in older patients, and honestly, it's much more widely used because it is much better tolerated with equivalent activity. What about maintenance options after Pemetrexit and platinum? So a few of them have been evaluated, including Pemetrexit, gemcitabine, and bevacizumab. So here in this study, CALGB 30901, patients who had received 4 to 6 cycles, that is every 3 weeks, of Pemetrexit and cis or carboplatin, were randomized to either just continue the Pemetrexit, it's a little easier than taking the double drug, or go to observation. And what you can see here is that there is no difference between these lines. In other words, continuing the Pemetrexit probably isn't necessary. It's a small trial, so we can't say definitively, but for most patients, you take the chemotherapy for 4 to 6 doses, then you go into an observation period. The ENVOLT 19 study was a Dutch study that tried a different approach called switch maintenance. After patients received Pemetrexit and platinum, they either got observation or they could switched over to the drug Gemzar. And here it looks like patients might have had longer disease control if they got Gemzar, but it didn't actually affect how long they lived. Again, a small study, provocative. I don't know that it's being used in the United States, but it's an interesting concept. Now, the first randomized study since Pemetrexit was approved was the MAPS trial, and this study looked at Pemetrexit cisplatin with or without the VEGF inhibitor bevacizumab, followed by maintenance with bevacizumab versus surveillance. And here you can see a nice discrimination between the arms of the study, such that the progression-free survival or the delay of the tumor growth was greater in those patients who received the bevacizumab. Similarly, patients lived longer if they got Pemetrexit cisplatin and bevacizumab than if they just got the old combination of Pemetrexit and cisplatin. So we learned from this study that adding bevacizumab improved that progression-free and overall survival. It wasn't too toxic, and it didn't make people feel worse. And so this combination is in the NCCN and ASCO guidelines, the guidelines that doctors use to tell us about treatment, but it isn't FDA approved for mesothelioma, so it's not always available via insurance. And being a French study, it was done only in patients under the age of 75, and for the most part, we will not give this drug to older patients because it does increase the risk of stroke and blood clots and nasty things like that. Now, what about first-line immunotherapy? I'll talk about the drugs Ipilimumab and Nivolumab. On October 2nd of 2020, the FDA approved the combination of Nivolumab plus Ipilimumab as first-line treatment for patients with unresectable malignant pleural meso. This was a wonderful day because it was when the first new drug approval for mesothelioma occurred after 17 years. Many negative studies happened in between, but this was a real red-letter day. All right, so Checkmate 743 was the trial that transformed our first-line treatment for meso. In this study, of over 600 patients received either Nivolumab and Ipilimumab, this is Opdivo and Yervoy, or they got Pemetrexit with cis or carboplatin. The study was actually stopped early because the results were so dramatic. That is considered a very large distance between these lines, and patients who got the immunotherapy lived a lot longer than those patients who got standard chemotherapy. Now remember, we talked about histology, the chocolate, vanilla, and swirl. So in the epithelioid, you kind of have to squint a little bit to see the difference between the arms. Indeed, there is an improvement even in epithelioid when patients got immunotherapy. But the epithelioids were kind of starting over here, and they went over here. The sarcomatoids were starting way down here, and they also moved up to here. So you can see that huge difference in the non-epithelioid patients, more than doubling of survival. And that's partly because chemo just doesn't work well in those patients, but also because immunotherapy works so much better. Now, what about Pdl1 expression? So that's that immune marker on the surface of the tumor. In those patients who had no or very low Pdl1 expression, the lines kind of crossed. It probably didn't matter which you chose. But in those patients who had Pdl1 expression greater than 1%, in other words, it was positive, you can see a nice separation between those curves, showing that immunotherapy was superior in those patients. So this summarizes the results and shows you how now with immune therapy, epithelioid and non-epithelioid patients can have equivalent outcomes. Really exciting. The tumor shrinkage was about the same with both treatment options, but the responses lasted longer in those who got immune therapy.
So the authors of this study were very excited because this study met its primary endpoint of statistically significantly improved survival with immunotherapy. And they felt that this should make the Ipi and Nivo combination the new standard of care, which it is. Now, when we have studies like this, we always want to look at long-term data. And so a recent analysis at 3 years of follow-up showed that there were no new safety signals, patients weren't getting ill further out, no other new problems, but 3-year overall survival still favored immunotherapy, and epithelioid and non-epithelioid patients still had basically equivalent outcomes. And about almost 30% of patients still had their tumors responding at that 3-year point, which is pretty remarkable, versus none of those who had gotten chemotherapy. Now, there are patients who get immune therapy who get immune-related side effects. They get the pneumonitis that makes it difficult for them to breathe, and the doctor says, sorry, you can't get any more immune therapy because it could make this even worse. And the patient's like, but I have to take my immune therapy, I'm scared to stop it. This data shows that it is totally fine to stop it. In patients who continued immunotherapy because of immune-related side effects, there was no bad effect of discontinuing it on the long-term benefit. These patients had only a median of about 4 months of treatment, and yet their survival was even better than in those patients who didn't have those immune side effects, and their tumors shrank 2/3 of the time, which is remarkable in meso, and 1/3 of those patients still had tumors responding at 3 years. When you look at these curves, the dotted lines are those patients who had the immune side effects, and they did even better than the other patients on the study who had gotten immunotherapy. Their immune system was so revved up, causing those side effects, that it also is still controlling that tumor. Now, if you didn't get side effects, it doesn't mean it's not working, but it's just reassuring that if your doctor says it's really not safe, your joints are hurting too much, you're not able to walk, don't put yourself in a wheelchair, it's okay to stop. The study also looked at quality of life using a variety of symptom scales and showed that immunotherapy delayed the time to which you would then be feeling worse. And so what's called delayed time to definitive deterioration in health-related quality of life. You feel better for longer if you're getting immunotherapy. Pretty nice. So placing this study in context, we know that compared with chemotherapy, the Pemetrexit and platinum, Ipi-Nivo yields superior survival at 1, 2, and 3 years, regardless of histology or Pdl1 expression. Now, Checkmate 743 clearly changed the standard of care for meso patients with the non-epithelioid histology. Those were the ones with the really dramatic improvement in survival. So now with doublet immunotherapy, epithelioid and non-epithelioid patients can achieve equivalent survival. But if you have epithelioid histology or a Pdl1 negative tumor, although Ipi-Nivo is still favorable, the choice between treatments is more nuanced. Chemo is still okay. And in fact, the survival from Ipi-Nivo is really similar to what we got with Pemetrexit and platinum and bevacizumab in the MAPS trial. So we're looking to see what other treatments might be best in patients with this subset. And ongoing studies of chemotherapy plus immunotherapy may be identifying regimens that are even better suited to that epithelioid subset. And I'm showing you here, it's called a spider plot and a waterfall plot. And just look at things going in the down direction, that means things are shrinking. So this is a phase 2 study looking at the combination of durvalumab, a Pdl1, with chemotherapy, showing really dramatic responses. So just a teaser, only one clinical trial in this presentation, but the DREAMER trial is comparing immunotherapy plus chemotherapy to just chemotherapy. And it may indeed change the standard of care. It is an ongoing study, but hopefully for those patients with the Pdl1 low and epithelioid tumors, that may be our next treatment option. So how do we treat meso that is worsened on or come back after first-line therapy? That used to be a much simpler question. Now that we have more frontline options, we also have more choices for second line and beyond. The choice of a second-line regimen depends on several variables. First of all, what you got beforehand. If you got chemo plus bevacizumab, or immunotherapy. And then what was your response to that regimen, and how long did it control your disease? If you got Pemetrexit and carboplatin and the cancer didn't come back for 2 years, you might want to get retreated with the same thing rather than trying something new. You want to also look at the histology, because that's going to come into play with immunotherapy as well as with GEM-RAM that I'll tell you about in a moment. And then what are some medical contraindications? Do you have autoimmune disease, lupus, or myasthenia gravis, or something that's going to mean that immunotherapy isn't safe for you? Do you have decreased kidney function and Pemetrexit isn't a good idea? Are you older and might have an increased risk of clotting or bleeding, so a VEGF inhibitor might not be a good idea? So in patients who have not received prior Pemetrexit, we know that single-agent Pemetrexit can delay the worsening of the cancer. And we also know that Pemetrexit or Pemetrexit platinum retreatment will achieve durable disease control in patients who are Pemetrexit sensitive. So if you responded the first time, you had a reasonable time off of therapy, you can get retreated again. But what is the activity of Pemetrexit platinum in patients who just got immunotherapy? Well, those studies haven't occurred yet. We assume that it's similar to frontline chemotherapy, but we really don't know. An interesting trial was the RAMES trial that came out of Italy. It's a rather unexpected result. Here, patients received a old standard in previous treatment, gemcitabine or Gemzar, with or without the VEGF inhibitor ramucirumab. And here we can see a very significant improvement in overall survival with the combination therapy. And interestingly, that survival improvement extended not only in epithelioid, who tend to respond better to chemos, but also to the non-epithelioid patients, offering yet another treatment option in the second or third line setting. VIM was a recent study looking at oral vinorelbine in patients with previously treated meso. Now, this is not available in the U.S. We have only the intravenous kind, which is a little more toxic. And here they compared it to best supportive care, which is a difficult thing to do in the United States, but in the UK, patients tend to be more accepting of this. And we can see a small improvement in the delay of the cancer worsening, so progression-free survival, but no survival change. Whether this is worth it or not is really unclear. Now, what about giving immune therapy? So the ETOP PROMISE study looked at either giving pembrolizumab, also known as Keytruda, versus doctor's choice of vinorelbine or gemcitabine. And then those patients who got chemo could cross over to the immunotherapy. And here we actually surprisingly saw no difference between chemotherapy and single-agent immunotherapy, and that was a little puzzling. The CONFIRM trial recently came out, and that compared immunotherapy to placebo, or a dummy pill, a dummy IV, and that did show an improvement in median survival in those patients who got Nivo versus those who got nothing, suggesting, that at least there is some benefit from single-agent immune therapy. But maybe you need the double drugs. So this was actually a non-randomized parallel study that looked at either giving single-agent Nivo or giving the combination of Ipi and Nivo. So not evenly balanced, a little hard to draw conclusions between the arms, but we can see that there does seem to be a longer progression-free and overall survival, as well as a higher toxicity rate when we gave the doublet versus the singlet. So whether we should be giving Ipi-Nivo in the second line or just Nivo, I think most of us would give the combination unless the patient was very frail or had very high Pdl1. So over the past few years, I'd say we have finally begun to make real progress in systemic therapy for meso. Combination immunotherapy has clearly changed the standard of care. There are many new treatment options for patients with this disease. Of course, far more needs to be done. Research into the biology of the disease continues to uncover new targets, and the Meso Foundation is at the forefront of funding that research, and many of our investigators are very involved in doing so. Many clinical trials of novel agents and approaches are ongoing, and I hope within a few years we'll be able to talk about many new breakthroughs that are going on in this disease. I thank you for your attention.
Do we have any questions? I think we have time for one question. And we have a couple of mics here. I can bring you the mic over. Anybody? No. I have a question, if you don't mind. Forgive me if you've addressed it. You said in first line, sarcomatoid patients benefited greatly from immunotherapy. What about second line therapy? How is that for sarcomatoid patients?
So the problem in sarcomatoid patients is that chemotherapy is just not very active. And so if a sarcomatoid patient has failed immunotherapy, there is a problem. We're not certain what the best treatment is. The data from the gemcitabine and ramucirumab studies suggests that patients who received that combination, who had non-epithelioid, so sarcomatoid tumors, did just as well as epithelioids. So I would think that addition of a VEGF inhibitor to chemotherapy would likely be the best approach as long as the patient could tolerate it.